Hi everybody, it's a great pleasure to participate in this think tank, Hearing in Later Life, and I'm really delighted to have the invitation from Megan and to talk to Kathy about it. We decided on this title, Hearing Care More Than Technology, because it's really dear to the hearts of both of us, and I'm sure of many people who are talking on this webinar. Partly it's just because I have this wonderful neighbour. There she is, Rosemary. Rosemary has macular degeneration, but she also has a cochlear implant for the past 4 or 5 years. And Rosemary has a husband he has dementia too, so she has a really quite a tough life. But I have learned more about hearing care and hearing loss and managing it in the last few years from Rosemary than many years in schools and clinics. I've worked with children who are deaf and are hearing impaired and adults for over 40 years now. But as I say, Rosemary's taught me more than many. And Rosemary also teaches me how much hearing is an essential part of communication. And in spite of everything, she's a very effective communicator, as you can see, and makes me laugh, which helps. Now, in this webinar, in this think tank, there have been some really exciting presentations, and we're all learning a lot. And some of what I'm going to say is summarizing that, I'm sure, because we know that the impact of hearing loss in adults is underestimated. We know it's associated with depression, with social isolation, with increased disease burdens, with poorer self-reported health, with cognitive decline and dementia, with greater use of medical and social services, and greater rates of unemployment. And let's forget underemployment. We also know that hearing loss is the #1 cause of years lived with disability in the over 70s. Many examples of these have been given in the references. If you have a look on the hearing care and the Spend to Save leaflets that are in the repository or available from European Cochlear Implant Users Group that my colleague Brian Lamb and I have done, you'll find many up-to-date references there. Now, Bridget Shields' report in 2019 about the social and economic costs of hearing loss is a fascinating document and a follow-up to her 2006 report, available from ahima.org and hearit.org. And she showed once more that the lower quality of life and productivity that's associated with hearing loss, the increasing evidence of health and psychosocial impacts. Now, looking at the changes from her 2006 report, she found that stigma was less of an issue in 2018 than in 2006, which is encouraging. She also found stronger prevalence data. So we're getting better at collecting the data and the evidence. She also found the stronger evidence for link with dementia, which we'll be hearing during this think tank and discussing. She also found increasing satisfaction with hearing aids, but still a significant percentage who would benefit from hearing aids unaided. And looking at the costs, she found that the social economic costs to Europe of hearing loss were over 216 billion euros per year. Now, we have the technology to change this, or to help. We've got digital hearing aids, we've got auditory implants, we've got assistive devices such as radio aids, FM systems. We've got really exciting communication technologies. You can see on the screen there, talking on iPads, talking through FaceTime, talking through Skype. We've got many ways of having the captioning almost automatically now, which is pretty effective. We've got telehealth services. There's Colleen Bazaros in Sydney, delivering cochlear implant services online via her iPad. So we've got the technology to really change the management of hearing loss today and that huge impact that we know about. And we do know that hearing aids and implants are effective. We've got that evidence. We know that earlier the better. We know that hearing aids improve mental health, physical abilities, cognitive abilities, and employability. The evidence grows and grows. We know that cochlear implants in adults, regardless of age, improves quality of life, reduces depression, and supports cognitive functioning. And we also know, of course, that the earlier hearing aids or cochlear implants are fitted, the greater the benefit that we can see. And we also know that hearing technologies are proven cost effective. Hearing aids are cost effective. We know that the use of hearing aids reduces the probability of hospital visits. It reduces the financial burden on health services. Similarly, we know that cost effectiveness of cochlear implants is well established. And the excellent review by Cavazzier and Hartmann and France in 2017 showed a return on investment of, if they invest €1 in hearing care and hearing technologies, then €10 were saved by society. This information helped to change the hearing aid provision in France. We've heard already from Shelley from WHO that the prevention and early identification of hearing loss is cost effective, and the provision of hearing devices is cost effective, especially if follow-up rehabilitation is provided. And we know from WHO that if we don't address hearing loss, it costs the global economy $750 billion annually. And their materials, of course, are available on the website, many useful materials. So investing in hearing technologies, we know it changes lives and it saves society money. If you have a look on the EuroCIU website, you'll be able to see the real cost of adult hearing loss, a document that Brian Lamb and I did about reducing the impact of the cost of adult hearing loss. It actually costs more not to do anything about hearing loss than to do it. So we developed the document Spend to Save. If we spend money on hearing loss and managing hearing care well, then we can save society money. And those are available, and that short document is available in many languages. So we know they work, we know they're cost effective. Is all well? Everything should be fine. Do we know? Well, we know that in the UK, from Work of Action on Hearing Loss, that 45% of those who go to their general practitioner are not referred on for assessment of hearing loss. When you get to a certain age, the answer usually is, well, what do you expect at your age? It often takes years for adults to get audiological help. We don't have adult hearing screening, in spite of the technology being there. I'm of an age where I'm screened for many things, but I'm not screened, of course, for my hearing. With hearing aids, according to Eurotrack on AHEMA and on hearit.org, the rate of device adoption for hearing care, it varies across Europe from 17% to 96%. So all is not well. For cochlear implant adults, we know the figures are even worse. About 5% of adults who could benefit in the UK, and it's the same figure throughout most of the developed world. So why is all not well? Well, the real impact of adult hearing loss for adults at home and at work is unseen. As adults tell us when we do qualitative research studies and listen, you lose your self-esteem, you don't want to go out. That's what deafness does to you. As Rosemary said, after she had meningitis in her 60s, it was like being put in a box. So the impact of deafness is underestimated. Another comment. I had a problem with psychologically accepting I was going deaf. It's not cancer or heart disease, but it's a different sort of disability which can leave you feeling isolated. And if you feel isolated, it can lead to depression. The hearing resources manager, the human resources manager would simply say, I don't know if you're up to this job anymore. You can't hear what people are saying to you. How can you do your job? It was frightening. I was possibly going so deaf that I wouldn't be able to work properly. So that really affects somebody's self-esteem and how they view themselves. This is the real problem of hearing loss. The impact of hearing loss is under-recognized and it's unseen, except by those who experience it, whether it's a child, parent, adult, and of course, the family. And it's rarely understood by the public or by public health funders. For example, if you have a look on the right of the screen at the picture and on the left of the screen, can you see the difference between the two pictures? This was used as an advert by Virgin Active with a deaf ballerina who was wearing a cochlear implant And when they used it for the advert, they photoshopped out her cochlear implant. Why would you do that if you had any understanding about the impact of hearing loss and the impact of hearing technology? She, of course, was incensed and insisted that they put it back in, and insisted that they went public about what a mistake they had made. Her hearing loss is part of her, and how she manages it with an implant is also part of her. Here's another example of the reflection that society places on the value of hearing. This is the amount per year spent on research in the UK in 2018. So if we have a look, £193 spent on cancer research for every person affected. £21 spent on cardiovascular research. £16 on vision. If we were face to face, I would be asking you to guess how much was spent on hearing. Not even £1. 83 pence, less than £1, spent on research into hearing. That's available if you wish to have a further look. But just an example of the value that society places on hearing. Because when you've gathered the evidence that we have to influence public policy, and we're all interested in hearing care and improving that, we actually need to get better at telling the story. And if you haven't read Hans Rosling's book called Factfulness, do advise you do so. This is really an excellent way. Bill Gates said it was the most important book that he'd read, about the figures and the facts about public health across the globe. It's how you tell the story that's important. And Hans Rosling realized that, because communication is changing, and how we tell the story must be instant, must be accessible. It must be understandable today. And we need to learn from others who influence using social media. And whatever you say about Donald Trump, he is extraordinarily adept and adroit at using the social media and how he uses his Twitter feed. And we need to learn how to tell our story. So here's my story. After 40 years of being involved in hearing care for others, I decided a year ago I should take my own advice, and went to see a friend, of course, to get my own hearing aids. Well, after 40 years involved with other people, I have to say it was a huge personal adjustment. For a start, fiddling with hearing aids yourself and putting them in isn't the easiest job in the world. Today they're tiny, which is great, but very difficult to manage. And what do you think this is? Well, this is to do with the wax filter. So here we are. I have to put the tiny bit of my hearing aid in there that's got the wax filter into here. And I can tell you that, I haven't got arthritis yet. I can tell you it's not straightforward. And this was a big adjustment, and a bigger adjustment than I realized. Things like going to the hairdresser and telling them that you had hearing aids, etc., etc. The impact that it had on everyday life was bigger than I had anticipated. I have to say, of course, they work. And Clark and English say about, and commented in their book, about the three-pronged stress of becoming deafened in later life. One, of course, is understanding speech with impaired hearing, which does affect so many people as they get older, but also adjusting to that new self-concept as hearing impaired and accepting that actually you need to do something about it. And adjusting to society's reaction to self as hearing impaired. The reaction of the hairdresser, for example, who you've known for years. But I'd add more to that. Managing the technology and professional languages and attitudes is something else to deal with. Because what we do, professionals, we give information and more information. We're good at that. And sometimes too much information can confuse and reinforce your feelings of inadequacy. I know about this field, but so much information came my way in a short appointment. It's difficult to take in. How much can people take in? How can we help them make informed decisions about what is the best way forward to manage their hearing and their communication? Do we add to feelings of inadequacy and frustration? I would suggest, if you haven't read David Lutterman's books, I also suggest another one, Counselling in Persons with Communication Disorders. And one of his comments is so true. When emotions are high, cognition is low. When you're feeling quite emotional about something, it's a very difficult time to make sensible decisions. And making decisions about your own hearing care, even if you are not entirely elderly, but is really challenging. And the diagnosis and the fitting of aids can bring a change to one's self-concept. You need time to adjust. As somebody said, I've always thought hearing aids were just for old people. And as you don't think of yourself as you're old, when you're getting older, you start to realize that maybe you are getting older. So a big change coming on. And the fitting of hearing aid implants brings about another whole set of issues. As well as dealing with the technology, you need to deal with the professionals, or usually in expert mode. I'm the expert in hearing model of hearing care. I'm the expert in hearing. That's a model of hearing care. And just an example here. Here's a patient coming into a hearing clinic, and the patient has been fitted with hearing aids and not finding them a bit of a struggle, and says to the audiologist, do I have to wear these hearing aids all day? Well, what is the audiologist going to say? Again, if we were face to face, I'd be asking for some suggestions. Well, one of the responses that the expert in hearing might say is, yes, you do, otherwise you won't hear what people say. Well, putting oneself in the place of the patient coming in, the person coming in, how far will this get you? I suggest not very far. If somebody gives that sort of response, they're clearly not listening to what the patient's concerned about, who may well go away feeling misunderstood, that somebody really doesn't understand the difficulties that they're having. So let's change the story and have a learning conversation response, which thanks to Chris English for all her thinking and work in this area, and change it and hopefully change the outcome. So the patient's saying, do I have to wear these things all day? And the audiologist, instead of the previous response, says, that's a problem. So we've got a leading conversation, a learning conversation. Let's find out what's going on. Yes. How so? Well, it's really hard. I'm on my own and we might find out then that this person who's come in with her hearing aids and is really struggling with them can't remember what was said, can't get the batteries in, maybe needs some retubing, whatever, but is really, really struggling. And they're on their own at home with nobody with them and don't know what to do. And unless we sort that out, those hearing aids are likely to be a pair that sit in the drawer. And we're not going to find out by being an expert model. Well, Chris suggests that having learning conversations, working with a bit of non-professional counselling skills can be really different to and counter to the professional nature. Audiologists may well not naturally be natural counsellors and need to perhaps think about that interaction with patients that they see. Chris did a study looking at the temperament of 372 distance learning students that she had. Out of the 372, 80% came out as guardian personalities, concrete, goal-orientated, reliable in actions, doing good deeds, so wanting to make people better, which is great. But 40% of the general population come into that category, only 40%. So it actually led her to think that the people who are coming forward to train as audiologists and functioning as audiologists were really quite a different population to the general population. And she needed to think rather more about their interactions with their patients and their counselling skills and their listening skills with their patients, so they could be even more effective than they were already. Because with patient-centered communication, we know when physicians use patient-centered communication, Patients are more likely to follow their recommendations. We know from studies in other areas that this is true. And this involves, we need to elicit and validate patients' concerns, listen to them, find out what's really going on, instead of having our own agenda in the clinic. Inquiring about and listening to their ideas, their expectations. Assess the impact of symptoms and what they're saying on their functioning, not just the figures on the computer. And using empathetic language. As Stone said, people almost never change if they don't feel understood. And if somebody is really going to take to hearing technology and hearing care and new communication skills and use them well and effectively, then they need to actually move forward in their lives. And they're not going to do that if they don't feel understood. And they need some time to do that, which of course is something that we're all short of. And today, particularly, people want to be involved in their healthcare. With the impact of COVID-19, people are particularly questioning healthcare decisions, public healthcare decisions, and so on, and want to be involved. Now, we know this can be really challenging in later life, but we need to find ways of doing that for all those who are experiencing hearing loss and needing hearing care later in life. Chris English's counselling courses that I've been privileged to run with her, Listening with a Third Ear, we need to forget the professional expert mindset and moved on. And as one person said, I've realised it's their clinic, not mine, not my agenda. We need to let the patients take more of a lead during the appointments. Again, not the audiologist's agenda. Because managing the technology isn't always easy. But industry is listening, things are progressing, but here we are with Rosemary, with a bag of bits, her remote programming, the book of instructions, not so easy with macular degeneration, pairing up her phone, again, not so easy and not straightforward always. And that long-term care after cochlear implantation or after hearing aids for adults, thinking about the ongoing adjustments, batteries, troubleshooting, linking to the phone, managing noise, communication strategies, the communication strategies needed in going out for a meal in such a setting as this picture, which is a terrible and really challenging place for somebody with a hearing loss to go to. Developing communication strategies and attending to one's needs and advocating for one's own needs can be challenging. We found that group sessions for adults, whether in community centres, GP clinics, in care homes, sheltered housing, have been shown cost effective to deal with these issues. Supporting individuals and groups with communication and technology sessions, giving them opportunities to learn, time, adjust, talk to others, have the experiences that may not be possible in a clinic setting. They say, it's great to realise it's not just me. I'm going back more confident. The audiologist was great, but I can't remember what she said. And they want to try somewhere where they've got time and they're relaxed. Getting retubing done, batteries. Here's Laura dealing with somebody who really has a very small problem with his hearing aids, but it's a huge one to him and a huge impact on everyday life when he can't sort it out. So to finish with, while thinking about hearing care, we mustn't forget that we need to support hearing care in the community for a lifetime. We're quite good at providing access for fitting hearing technologies, programming, assistive devices in the clinic. We're not bad at helping to use the technology with family programs, sessions, group sessions, but we're really not good at supporting long-term use of hearing aids or implants out in the community, whether it's at home, whether it's at school for the little ones, or whether it's at work, whether it's in a care home or whether it's in a sheltered housing environment. Wherever it is, then looking after hearing care and the technologies and the communication strategies is not something that we're entirely good at. So we really mustn't forget that the long-term management and the funding needed to go with it. So to summarize, we're talking here about hearing in later life, and hearing care is crucial to healthy aging. And whether it's effective, it has huge personal impacts on quality of life and on society. And today, we've got the hearing and communication technologies to help. And one thing the pandemic has done is made us all more confident in the use of some of those technologies. But we're still not always good at managing it or the joined up thinking that's required. Now, involving users, we need to make sure that they're involved at all stages of delivering and managing hearing care. And that's where qualitative research has become so important, and it's so good to see much more recognised today. Because what is really needed may not be what is being delivered, and the Rosemarys of the world know what they need. And it's about communication. And we really need to listen to the Rosemarys of the world as we move forward with hearing care and as we talk about hearing in later life. Because effective hearing is a huge part of communication, which is what makes life special and is what makes healthy aging really important, and healthy aging actually possible with effective communication. So thank you for listening and for your time. And I really look forward to the exciting discussions that I'm sure are taking place and are going to take place during and after this think tank. Thank you very much.